Assalamu alaikum. On behalf of Ahsan Academy, let me welcome you to a presentation on the general organization of the abdomen. In this part 1, let me discuss the general idea on the abdomen, regions of the abdomen, and we will try to draw that on the living surface. How the abdominal wall is formed and the general aspects of abdominal cavity will be discussed, and finally at every stage we'll try to correlate the subject clinically. So this is the trunk of the human body. You can see this is the central trunk part of the body to which the neck and head, the limbs are attached. So the central part of the body is known as trunk. Of this trunk, the proximal part or upper part is the. Let us see the median section. This is the central partition which divides the thoracic region from the abdominal region. So this is the diaphragm, you can see on the left figure, and above the diaphragm the part is thorax, and this below the part it is the abdominopelvic region. So below the diaphragm, the total part is not only the abdomen, it is comprising of abdomen proper and the pelvic cavity. So look at this area. Behind the bone is the sacrum, and this is the upper limit of the sacrum, and the hip bone, this is anteriorly, this is the pubic part, and this is the upper limit. So this upper limit, when we connect, this is the inlet. The plane is called the inlet. So the part proximal or above the pelvic inlet is the abdomen proper, and below this is the pelvic cavity. So together is known as abdominopelvic region. You can see this is the abdominopelvic total region. Now we can see the area, this is the diaphragm in a better view. So above this is the thorax, and below this we have to draw another line from this upper limb sacral promontory to the upper part of the pubic symphysis. This is the inlet region. I am drawing here, shading this area. This is the inlet of the pelvis. So below this inlet is the pelvic cavity, and this is the abdomen proper. So this one is the pelvic cavity. So this is the overview of this abdominopelvic region. This region contains many organs. It's clinically especially significant because the abdomen is the area which is most frequently affected by the diseases. Now look at this map of the wall. We divide this total wall into various areas. This by the grid lines, and divides into the small grids, and it's still smaller. The aim of this is so that we can identify the area on the wall. We can identify a particular area by mentioning this grid position. So these divisions helping us to study the map, to locate the various areas in the world. So in the same way, if we look into the abdomen, it's full of organs. So we need to specify the location of the disease, location of the problem, location of the organ that is affected, the part of the organ that is affected. So with this aim, this abdomen is divided into different regions by several lines. So we can draw those lines on the abdominal wall. Every time, whenever we want to draw any line, draw any point, make a surface anatomy or surface projection of an organ, we use some certain landmarks present in the body, and we use the bones mostly because it is very easy to identify the feature on the bone, location of a particular end of the bone. So this is relatively fixed in position, so we can use those as the landmark. So here also we will use the landmark. Mostly we will try to use the landmark of the bone to draw these lines. We can divide the abdomen by 4 lines, 2 vertical lines I have shown here, and 2 horizontal lines. One is above, another is below. So this total abdominal wall is divided by 4 lines into 9 regions: 1, 2, 3, 4, 5, 6, 7, 8, 9, and each line has a particular way of drawing and has specific name. So these regions are also having specific name and are used to locate or express the anatomical location of the organs. Let's see this one. So to divide the abdomen into different regions, I'll draw some line on this figure. In case of abdomen, we draw the lines on the anterior abdominal wall. There are 4 lines, so the 4 line divides the anterior abdominal wall into 9 regions. This I will try to show you on the anterior abdominal wall in this figure. You see, this is the sternum, and this one is the jugular notch, also known as suprasternal notch. Usually we use the bony landmark to indicate something on the surface in the living anatomy. So this is the very good place which can be easily identified. So jugular notch is this one, and if we place our index finger and roll on either side, we will get the medial end of the clavicle, making joint with the sternum. So this is the medial end of the right clavicle. If we roll the tip of the index laterally, we will get the lateral end. So this is the lateral end, this is the medial end. If we draw the line and find the midpoint, this is the mid-clavicular point. So this is the midpoint of the clavicle. If we draw a line vertically downward, this is right mid-clavicular line, and in this plane the right mid-clavicular plane lies. Now this is the thoracic case, and these are the costal cartilage. The 7 costal cartilage attaches to the articulates with this sternum, but 8, 9 and 10 articulates with the cartilage above. So this is making the costal margins. So it's very tough to identify the tips, but it is identifiable. Now if we draw the mid-clavicular line that curves the tip of the 9 costal cartilage in the costal margin. So this is the way we can confirm that this is the position of the tip of the 9 costal cartilage, which is a very important landmark. Now if you go further, this is the hip bone, and this is the iliac crest, easily identifiable, and anterior limit of the iliac crest is anterior superior iliac spine. So this is this limit of the groin, and this one is the groin, and this is the midpoint, midline. Symphysis pubis is there, that upper limit is there. So this is the groin, and we used to say this is the mid-inguinal region. So we can draw a line here and can find the midpoint, mid-inguinal point. So this line crosses the tip of the costal cartilage, 9 costal cartilage in the costal margin, mid-inguinal point here. So with this line we can get extra benefit also. So this one is the transpyloric plane, this one is the transtubercular plane. Now already we have discussed the mid clavicular line showing that it is crossing the tip of the 9 costal cartilage and mid inguinal point. Let us move to the second one. This is the transpyloric plane. How to draw transpyloric plane? The same way, this is the jugular nose, pubic symphysis. Midway between this is 1 point and horizontal line. This is the transpyloric line. Interestingly, this transpyloric plane or line curves the costal margin at the tip of the 9 costal cartilage. So these two will meet in front of or just superficial to the tip of the 9 costal cartilage. That's an important landmark. So if we can find out the tip, then we can connect these two tips of the 9 costal cartilage and can go get the transpyloric plane, or we can find this midway. Now it is very tough to expose the whole area in a patient. The patient usually allow you to expose these areas to identify the disease. So you can get this joint, body of the sternum and xiphisternal joint and umbilicus. So the second way we can draw a line connecting the umbilicus and the xiphisternal joint, and this is the midpoint. So if we draw a horizontal line in this way, then this point will give a clue and will help you to draw this transpyloric plane, and this is clinically usually we do it. This one is the transtubercular plane. This is the iliac crest, and if we follow the iliac crest, we will get one tuberosity here, tuberosity of the iliac crest just behind the anterosuperior spine. So if we connect these two, this is known as transtubercular plane. So joining the tuberosity of the iliac crest will give you the transtubercular plane. In this way, we can divide the abdomen into 9 regions. Sometimes other planes are also used. This is subcostal plane. In some purpose, this is also used. And this one is the plane passing through the highest point on the iliac crest. So these two are other planes which will help you to identify. You see, this is the anterosuperior iliac spine and this is the symphysis pubis upper end. Now if we connect this by a line and identify the midpoint, this is the mid-inguinal point. But you see, this is the anterosuperior iliac spine and it is pubic tubercle. Between these two, one band is remaining. This is inguinal ligament. So it is shorter than this line. So the midpoint of the inguinal ligament is a bit lateral to this mid-inguinal point. So mid-inguinal point and midpoint of the inguinal ligament are not the same. And mid-inguinal point, that is between these two midpoint, is a bit medial than this midpoint of the inguinal ligament. So I think this is clear. So we have identified some landmark on the anterior part of the thorax and abdominal wall to draw this line. And you see the diaphragm is projected into the thoracic cavity, and you see this mid-clavicular line, this diaphragm is on the left side, it is 5th intercostal space, and on the right side it is the 5th rib. At this level the diaphragm lies. Because on the right side it is a bit higher because of the presence of the lever, pushed by the lever. This is the point xiphisternal junction, rise at the level of the 8th thoracic vertebral body. This is the xiphoid process. This one is the costal margin. It's umbilicus, iliac crest. This is the inguinal ligament. So these are easily identifiable on the surface of the thorax as well as abdomen. This is pubic symphysis. How the abdominal wall is formed? We should always try in a systematic way. So outside is the skin. After that we will get the superficial fascia as usual. And superficial fascia here in the abdomen is a bit different from the other region. Here the superficial fatty layer is very thick and is variable from person to person. And inside that there is well developed deep membranous layer. And deep to that is the deep fascia, which is very thin and is even not identifiable. After that we will get the layers of muscles. So the skin, this is very mobile, easily this can be moved, except some region where it is tightly adherent is the one is the umbilicus. This is the scar. This is the site of attachment of the umbilical cord of the fetus. So this region skin cannot be shifted. In the midline, the skin is tightly adherent to the deeper tissue. It is the linea alba, and then is the rectus abdominis muscle, and all lateral to this another margin is there. This is known as linea semilunaris. Thus in this region the skin is a bit tightly adherent to the underlying soft tissue. The skin important is the sensory supply, and segmental sensory supply is known as dermatome. So if we have a close up, we will find that the 6th thoracic nerve covers the xiphoid process. 10th one covers the umbilicus. This is clinicians are mostly using this one. The umbilicus means 10th thoracic. This is the inguinal region, groin. This is the lumbar one. So we will try to identify or remember these areas and then can imagine what should be above, which one area is supplied by 8th or 12th thoracic or like that. It is all over the body. It moves like this. Area covers like this one. Superficial fascia comprises of superficial fatty layer and deep membranous layer. This is especially important for the abdominal region. You see this superficial fatty layer is thick in the lower half and more thick here in the lower part. You see this is the superficial fatty layers, indicating here that it becomes very thick in some persons as reserved fat and makes a tummy, large tummy because of this fat. This is the superficial fatty layer. Under that, a very tough, thicker membranous layer is there. Membranous layer is especially clinically significant because it is separated from the muscle by the deep fascia, which is very thin, and a potential space lies between deep to the deep membranous layer. And we will discuss this one clinically in this subsequent areas. So this is thick connective tissue layer, and this is having bony attachment inferiorly. This is attached anteriorly to the pubic tubercle. You can see this is the pubic tubercle. Then this deep fascia fuses, this membranous layer fuses with the deep fascia of the thigh. So it is about 1 centimeter below the inguinal ligament. So from there to this is the inguinal ligament, and below 1 centimeter this is fused with the deep fascia. You can see this is the green line, a yellow line is showing this one, and pubic, this is the pubic bone, hip bone, three parts, ilium, ischium, and pubic part. So body of the pubic bone gives attachment. So you can see the membranous layer is fused here. So anything deep to this membranous layer will not be able to go beyond this line, but this is free and will go to the perineum, means area between the thigh, lower part of the trunk. This is exposed. So this fluid, if we pour under the membranous layer, will not be able to go to the thigh. The gravity will pull this to the perineum, and here the genital organs are there. So the wall of the genital walls will be swollen because of the fluid, but that fluid will not be able to go to the thigh. This one is the pubic arch, so the attachment continues here. We will try to see this attachment in a clear way. This is the area. So the thigh is totally separated from the trunk here because of the attachment, and the space deep to the membranous layer lies in the abdominal region, moves to the perineum. You can see this is the area. So inferior attachment already we have discussed. This is the pubic tubercle, deep fascia, body of the pubic arch. This is the attachment I am showing here by line. Now looking from the down, thigh is removed. So this is the perineal region containing genital organs. So this one is the urogenital diaphragm. The floor of the pelvic cavity is having the pelvic diaphragm and urogenital diaphragm. The anterior part, this is the pubic arch, and the floor is formed by the urogenital diaphragm in case of male and female. Ischial tuberosity is there. Here you see this is the margin. So this membranous air goes behind and fused here. This is the line, the posterior border of this urogenital diaphragm. So fluid will come here and will start here, move to the wall of the genitalia. So this spatial space deep to the membranous layer is a potentially closed space. We can see this is pubic tubercle, so fusion is there, continues into the peritoneum, in the wall of the genitalia. So if you pour fluid here, that will collect here and then move to the perineum. Perineum will be balloon-like, then will be in the wall of the penis or in the genital, external genital of the female. So the fluid cannot pass to the thigh. You see, this is the region, perineal region. So this will show some fluid. Now, the significance, how it happens. See, you can see this figure. What happens in case if the paddle is slippery and somebody suddenly got slipped on the paddle, so will fall on the rod. The perineum will fall on the rod. So this will happen. So there will be a sudden injury to this part of the penis, and so lies urethra. The urethra may be ruptured in this case. So urethra, if ruptured, the urine will come out of the urethra in the space deep to the membranous layer. So urine will collect in the wall of the abdomen. Because of the gravity, this will go to the perineum, will cover in the will be in the wall of the scrotum, and will even in the penile wall. But this will not go into the thigh. So this indicates that there is rupture of the urethra, pouring the urine into the space deep to the membranous layer. Rupture site is this one. So the urine will be deep to this blue colored membrane in this region. So this will be, because of the gravity, this will first appear in the perineum, then will go to the wall of the scrotum and penis genitalia, then above in the lower part of the abdomen, and will increase and increase, but thigh will be spared. So rupture of the penile urethra, urine in the space under or deep to the membranous layer, this is the root. Will collect in the superficial part of the perineum, in the wall of the genitalia, means penis and scrotum, and labia major in case of female, and lower part of the abdomen. In the superficial fascia, we'll get some important structures. Means superficial veins are the most important structures. It's an indication of some clue to some disease. There are nerves there, small arteries there, lymphatics, but the superficial veins are more important clinically. The veins are arranged in superficial set, but arteries, corresponding arteries are not there. Arteries are deep in position, but vein accompanies the deep arteries and also remains in the superficial set. Now let us see this. This is the heart, and the blood from upper part, means head, neck, thorax, upper limb, follow the superior vena cava, enters into the heart. All from the lower part, including the abdomen, follows the inferior vena cava, opens into the heart. Now superficial veins are there that connects this lower limb vein with the upper limb veins. So there is connection on the lateral side, the superficial vein running between these two. So any obstruction of the superior vena cava, the blood will follow this route to the inferior vena cava and will go to the heart. So these are not that much dilated to accept this vein. So veins become very dilated and become visible under the skin. So this collateral circulation, these connections are present in the superficial fascia of the lateral side of the abdomen as well as the thorax. So these are the important veins to identify the obstructions. So obstructions, one is if it is superior vena cava obstruction or inferior vena cava obstruction. Another one is around the umbilical there is anastomosis. There are some veins that is connected with the portal vein. So this is the umbilical vein, and if the portal obstruction is there, the backflow of the vein will cause dilatation of the vein around the umbilicus. So this portal obstruction, the paraumbilical vein will regurgitate the blood back, and there will be dilatations of the vein around the umbilicus. It is radiating light. So this area will show the dilatation of the veins. So two types of dilatations are observed. If in case of portal obstruction, there will be vein around the umbilicus, dilated vein. And in case of superior or inferior vena cava obstruction, there will be dilatations and tortuosity of the vein on the lateral side. So let us see the clinical. Here you can see the lateral veins are very, very engorged. So there is vena cava obstruction. You can see the lateral vein going to the axilla. So this is because of the vena cava obstructions. Now there are dilatations of the vein around the umbilicus. This is known as caput medusa. This is because of the portal obstruction. It's a mythology is there. The medusa had snakes as the hair. So their swollen hairs looks. This is from the top view. Looks like a top view of the caput head of the medusa. That's why known as caput medusa. So clinically, dilated veins may be of two types. Caput medusa is visible in case of portal obstructions, and lateral vein, these are engorged in case of superior or inferior vena cava obstruction. Deep fascia is very thin and it lies deep to the membranous layer of the superficial fascia, and already I have discussed the clinical importance of this region. Muscles of the abdominal wall. Look at this skeleton. Abdomen has only the skeleton, the vertebral column, and the pelvis is having a skeleton with the lower part muscular. So these empty areas are filled up with muscles. So this anterior portion is softer, and anterolateral part, this gap is filled up with the layers of the muscles. The skeleton is present on the back and around the pelvic cavity. So anterolateral muscles are sheet-like and has thin tendons, so this is aponeurosis. So muscles and aponeurosis making the anterior wall as well as lateral wall. Posteriorly, this vertebral column has some muscles. So this is pelvic girdle and this one is the thoracic cage. So between these two margins, this area is having softer layer collections of muscles and aponeurosis. So muscles are in layers and making the wall of the cavity. You can see this is one muscle forming the anterior wall, anterolateral wall, and the posterior wall is musculoskeletal. So this is anterior abdominal muscle. It is known as rectus abdominis muscle, and one small muscle is the pyramidalis. Lateral wall of the abdomen means anterolateral part is formed by layered collections of muscles and aponeurosis. The posteriorly there is vertebral column as well as some muscles lying posterior to and side of the vertebral column. The fusion on either side, the aponeurosis makes the linea alba. You can see the muscles distribution, the gap between the iliac crest means pelvic inlet. This is the upper part, iliac crest, and this gap of the costal margin is filled up by the muscles. It's softer, but very strong. So it's a multi-layered muscular aponeurotic wall. It contracts to increase the intra-abdominal pressure. You see, this can allow the distension. If we take large amount of food, no problem. The pregnancy causes large enlargement of the uterus, accommodation of the fat in the mesentery. All can be done because of the softness of this wall. So what is the function of this type of wall in the abdomen? These muscles together creates a tremendous pressure and also some responsible for movement of the trunk. Can pull and depress the ribs and compress the viscera by tremendous increase in the pressure. All these activities are responsible for some physiological activities. So these muscles helps in movement of the trunk and in forceful expiration, compression of the viscera leads to defecation, micturition, parturition means baby delivery. So defecation, micturition, childbirth, all physiological processes are assisted by this type of abdominal. Thank you very much for remaining with this presentation.